Hi everyone, I am Joan Baumac. I am from Premià de Mar, which is a small town 25 kilometers away from Barcelona. I perform my clinical practice in the city of Barcelona, where I'm doing my courses on direct anterior composites. Also, I'm lecturing and doing my courses also internationally. And well, the majority of my work consists on direct anterior restorations. This lecture is just to show my experience on that field. I'm gonna try to explain how to achieve excellence on these direct restorations on the anterior teeth area by a non-invasive biomimetic approach. So I'm going to try to explain how to obtain natural-like results in a predictable way. A lot of people ask me why I love so much composites, where just is a matter of I feel some benefits for using composites. Of course, there's the artistic part of the work. I love this kind of artistic work since I was a kid. This is, of course, one of the reasons. I is fun time for me. So, of course, I'm gonna try to choose when I can. Also, there are other benefits, and maybe the main reason I'm gonna choose composite is because composite allow me to do non-invasive works. Maybe in the 90-95% of the cases I can perform non-prep treatments. For me, this is a great advantage, a great benefit that composite resins provide. Maybe in the cases of with ceramics, it's gonna be the opposite percent. Maybe that kind of maybe 10% can be non-prep or 15%. I don't know, depend. But most of the cases we need to do some kind of preparation. So direct composites allow me to do non-invasive treatments. Of course, I'm thinking of an aesthetic treatment. So this is something that make me feel really safe to perform responsible aesthetics. Also, this first benefit that for me is the main reason give me another advantage, and this advantage is that allow me to perform reversible treatments, and this is also something that I feel that is really good, is great. If I need, I can go back to the origin. Maybe I will have intact teeth down the restoration, so it means that I have the chance for just going back to the origin, to the original situation, if it's needed. This never happens. The patient normally is happy with the treatment, so of course, not gonna ask for just remove the treatment, but I have the possibility. So this is something that direct composite restoration, non-invasive direct composite restorations allow me to obtain this reversibility. And for me, this is also something great. And there's another benefit that I feel that is something really interesting, is that direct composite restorations can be repaired. And this is something really good, a great advantage, because of course, if the patient have some accident, have some fracture, I can fix that fragment with a partial reparation, and everything gonna be as nothing happened. Of course, I have to take note of which material I'm using, which layers I have done, and then I'm gonna be able to just repair it, and this is gonna be completely integrated in the restoration, lengthening the life of the restoration. So this is something really good, because maybe just if even is no need to repair, just in some years after the treatment, the restorations start to look a bit with some wear process on the surface, something similar. It's just possible to remove a layer, add some material, new material, and I'm lengthening the life of the restoration. So I feel that this is something really good, and I would like to, if I can, take advantage of that situations. Another thing, of course, everything have a beginning. Now I'm used to work with the composites, and I feel comfortable working, and I can solve the situations easily. But what happened? Of course, everyone starts, and in the beginning, maybe we don't have yet the skills for mastering the work with the composites. And another advantage, composites allow us to just remove partially a restoration in the next appointment, or just remove a whole layer and redo it and do it again. For example, nowadays, even I'm feeling comfortable working with composites, sometimes we have cases of single central fractures. This is a challenging situation. This is really difficult situation where is necessary to mimetize the restoration with the environment, with the surrounding teeth. Is necessary to emulate a sound central. This is really difficult situation. But of course, I can just perform the restoration. I'm gonna try to do it because I'm gonna follow the way I'm doing, and I'm gonna try to obtain predictable results. But of course, single central is difficult, so it doesn't matter. The next appointment, I can do some adjustments. Maybe I can remove a little part of the restoration, just do some adjustments for obtaining better results. So I feel these are really good advantages that, of course, I want to have on my side. So which is the little the difficult part for obtaining these advantages that direct anterior restoration, so just composite restoration, have a long and slow learning curve. So it is difficult to obtain the skills and experience for mastering the composite restorations, mastering the composite, the work with the composites. So it takes time, it needs experience, and to practice a lot and to learn a lot from other clinicians. And once you're mastering that work, you can have all these benefits. So for me, this is something really cool. It's something great to have all these advantages. Of course, if we are mastering composite, we can reach results equal to ceramics and having all the advantages. So of course, my choice will be composite. Of course, sometimes ceramics if it's needed. But if I can choose, I'm gonna use composite resins for solving the aesthetic treatments. And of course, I'm gonna try to perform always responsible aesthetics, and composites allow me to do that. Okay, so just I can start from situations like this to this, doing nothing, just air abrasion over the surface. So I can solve situations like this with natural-like results and being conservative. So for me, this is something great. These are the reasons why I'm loving so much composite work, and why I work almost exclusively on this kind of restorations in the anterior area, because of course I'm having fun doing it, but I have all these benefits. So of course we have to check which situations we are facing, and when we can perform these non-prep treatments, these non-invasive treatments. We have different situations. For example, situation A, I'm gonna be additive. Additive treatments, I'm gonna increase the whole volume of the buccal area from cervical to incisal, or maybe even not reaching till the cervical margin, but almost. Just I'm gonna increase, I'm gonna be additive, okay? In that cases, maybe can be direct composite veneers. I can be non-invasive. I'm not gonna do any kind of preparation, only I'm gonna perform air abrasion over the surface. In this situation A, I mean situations where I don't have to do anything else than air abrasion. I have natural sound teeth with no wear process on the edge, with no fractures, everything round and smooth and natural. So in that situation, I don't need to do anything else than air abrasion. I have other situations, situation B, also I'm talking about direct anterior composite restorations, the composite veneers, sorry. And here in this situation, the difference between A and B is that here I'm gonna lengthen a little bit the natural tooth. So I'm gonna have, imagine I have the situation, I have sound tooth, no edges, just rounded contours. I'm not gonna do anything else than air abrasion also in this situation. I'm gonna increase the volume from the cervical to the incisal, maybe even not reaching the cervical margin, but some situations yes. And if I have sound tooth, rounded contours, not edges, just air abrasion will be enough. There are other situations. Also, I'm gonna label it here in the situations B, where I have to lengthen because of a little fracture, because of a wear process on the edge. So in these situations, I'm gonna do air abrasion, I'm gonna do the same. I'm not gonna prepare, but I have to round a little bit the edge caused by the fracture, consequence of the fracture or the wear process, because I want to increase the biomechanics of the restoration. So in that cases, I'm going to be the same non-invasive, just air abrasion, but I'm going to round a little bit these sharp edges. So this could be the situations A and B. Maybe we are talking here of direct anterior composite veneers and additive cases. After we can find other situations, of course, and these other situations can be, for example, situation C. In this kind of treatments, I'm gonna keep the natural contour of the patient's tooth, the surrounding teeth, show me where is the natural contour, because maybe this could be the situation of a fracture, of a worn out central, worn out incisors, that I have to keep this natural contour. So here I'm not gonna be additive. Of course, I'm gonna be a little bit additive, but I wanna just differentiate from these two situations from these other situations. Okay, so this will be the situation of where I have a fracture or I have a worn out tooth and I have to lengthen keeping the natural contour. So in these situations, for being able to do this and hiding the fracture line and mimetize the restoration with the tooth structure, I'm gonna do a little preparation. This is a minimal invasive prep, and what I'm gonna do here is rounded bevel. I'm gonna explain with some examples soon, but here I'm gonna do a little prep. Okay, this is a minimal invasive prep, and this could be the situation of a class 3 restoration, class 4 restoration, or class 5 restoration. So as I said here, I'm keeping the natural contour of the patient's tooth. In this other case, I'm gonna be additive. So it's the case of direct composite veneers. I'm gonna increase the volume of the buccal area from cervical to incisal, or almost reaching cervical, maybe no need to reach completely the margin. Okay, but these are the different situations that I'm gonna just differentiate when I'm finding a case. So these are some examples. For example, I have here this case. This is the case after orthodontic treatment. I'm gonna talk about this case on the next lecture. The next week I'm gonna be here also, and I'm gonna talk in deep about this case. I'm gonna show the details. I'm gonna show you a step-by-step of this case for performing non-invasive composite restorations. So as you can see here, I have this case, sound natural, tooth, rounded contours, not worn out edges, no fractures, everything rounded and smooth. So here I'm not going to do anything else than air abrasion. Just going to perform the air abrasion, and I'm going to do an additive work, and I'm going to solve the situation like this, being completely non-invasive. The patient's teeth are totally intact down the restorations. For example, I have this other situation. It's quite similar. I'm going to do exactly the same. I just want to be additive, okay? So I'm going to perform air abrasion at all the teeth, rounded contours, smooth edges, not sharp edges any place. So the only thing I'm going to be here is partially erase a little bit, partially remove this deep white spot, because here, particular here, I cannot do any kind of infiltration treatment or similar for solving the problem. So in these cases, I'm gonna just partially remove this white spot and to obtain the enough space for hiding it. But the rest will be completely air abrasion, nothing else, non-prep. And then I'm gonna find other situations that could be similar as this one. Here we can see just worn out edges. We can see old composite restorations, class 4 restoration here in the lateral. So in this situation, I'm gonna do the same, air abrasion, but I have to round a little bit these sharp edges for increasing the biomechanics of the restoration. And of course, in this lateral, I have a fracture. I'm gonna do a minimal invasive prep, and so I'm gonna do a rounded bevel. I'm gonna explain a little bit more the rounded bevel now on. So I can solve the situation just being additive, just being non-invasive, just a little adjusts in that sharp edges, and that's it. Let's see another case. This is also a case after alignment. Orthodontics is just a good idea for just placing the teeth of the patient in the right place and then doing non-invasive cases. This is really good situations and facilitate a lot the cases for being non-invasive. So this is the treatment. This is the situation after the alignment. So just being additive is possible to solve here. We have some worn out edges here. There's some wear process going on the centrals, not on the canines, a little bit on the canines, not so much. Just I'm gonna round a little bit, even cannot be visible, but this is I'm gonna perform the air abrasion over the surface, so this is enough. I'm gonna perform additive composite restorations. Here the same. In this case, I'm gonna have, of course, to modify the shade. There's the patient's request was just improving the color. So I'm gonna perform an additive work. I'm gonna perform, as I said, the air abrasion, but as you can see, we have these worn out incisal edges. So if I have this wear process, as you can notice, I don't have it in the posterior. I have it from the canine, from canine to canine, so only in the anterior area. So I'm gonna round a little bit these edges. The rest will be only air abrasion. Of course, here also I did a little gingivectomy here on the centrals, and the rest is just additive work, nothing else. So this is another example. Let's see the last one of these kind of cases. Another case after alignment. So here in the laterals and the canines we have sound, intact teeth. I'm not going to do anything else than air abrasion. Here, as you can see, I have a little fracture in one of the centrals, and I have this other central with some wear process going on here. So what I'm gonna do is just round a little bit these edges. Here I'm gonna do maybe a bit more rounded bevel, and I'm gonna perform additive treatment. I'm gonna solve the situation being non-invasive. So these are the cases, some example of the cases of these non-invasive treatments. The situation A and B. Here I'm combining in some of the cases situation A, I'm combining situation B, but just this air abrasion. And also we've seen some situation C where I did rounded bevel, okay? So normally on the cases we're gonna find combined situations, but if we can just try to just perform the air abrasion, it's gonna be perfect. If not, we're gonna try to do microinvasive I'm gonna talk about now. So this is the situation C. This, for example, is the single central fracture. We have this edge here, and in order to be able to hide fracture line, I will need to perform this rounded bevel. I need to obtain a little bit of space in order to mimetize the restoration and in order to be able to hide fracture line. So this is the situation C. This is preparation, okay? This is progressive and round and smooth surface, and as you can see, there is no limit. What I mean, there is no limit. I have no shoulder, no any limit that indicates here I'm finishing the rounded bevel. So which advantage we're gonna have for that? That I can spread the restoration till it disappears. I'm thinning the layer till it disappears in the natural enamel. So this will make easier to mimetize the restoration. I'm gonna get that space with the deep bevel more close to the edge in order to hide the fracture line. So close to here, I'm gonna have this space that will facilitate to hide this fracture line, but I have no limit here. So the layer of composite will get thinner and thinner and thinner till it disappears. So it's gonna get mimetized with the natural enamel. So let's see another example of this situation C. This is another case of fracture, this time both centrals. So as you can see, this is the rounded bevel, and I wanna just overlap these two slides to check how minimally invasive is this rounded bevel. Okay, this is just a matter of remove these little spikes of enamel, be a bit, sorry, I'm just going, okay, just going a bit deeper here in the, close to the edge, close to the fracture, and just progressively going rounding and smoothing till I don't have any kind of limit, so I can mimetize the restoration. So these are that goals for this kind of minimal invasive preparation for me. So as I said, my first goal for every case, I'm gonna try to be non-invasive. I'm gonna try to perform responsible aesthetics. I'm gonna try to do non-prep, non-preparation. So if I cannot do non-prep treatments, I'm gonna try to do micro-invasive treatments. If I cannot be able to do micro-invasive because the situation require some other things, okay, I'm gonna be minimal invasive, but I'm gonna try. Of course, my goal at the beginning will be the non-prep, okay. To facilitate this kind of non-prep treatments, the wax app will help to this. And I'm talking about additive wax app. What I mean for additive wax app, I mean additive because will be without trimming the original stone cast. If I'm not trimming the stone cast, I'm just gonna be additive with the wax. So it will help me to design these additive works. I like to do the wax app myself, and I like to do it in a traditional way because this will give me some advantage. I'm gonna have the chance of just testing the anatomy twice. I'm gonna do it once while I'm performing the wax app with the ease that represent working over the stone cast. I can just switch. I can find the good position for just solving that tricky points of the tricky anatomical points. And the second time will be during the direct approach. And this will be, as I said, the second time. The second time we are doing something is much easier than the first time because we have found the problems there in the first time. So the second time already solved that problem. So this will be easy, even that we are working on the direct approach over the patient's mouth. That for sure is more difficult situation than working with the stone cast. But of course, will be again the second time I'm doing this. So for me, it works. I like to perform it. Sometimes, of course, I'm doing it digitally or I'm just ordering to lab technician if I have no time. But most of the cases, I try to do it myself for these reasons. And I really feel it helps just to perform these non-invasive treatments. So I'm gonna just talk about a clinical case now, and I'm gonna explain a little bit how I'm managing for just designing these non-invasive treatments or how I'm facing these kind of cases. This is a dentist. She came to the clinic asking for replacing this class 4 restoration. She was not happy with that. And also she asked me about doing something else to improve the smile. Of course, my first recommendation was to perform orthodontic treatment. We have some little rotations, little things, not big thing. This is not just a severe case, but if we can fix these little things, maybe it's gonna be easy to reach that aesthetic result, and this even will allow me to be non-invasive. The patient denied that alignment, that orthodontic treatment. She was dentist and she told me that I was not going to do this alignment, so she asked me to solve this treatment in a non-invasive way. Of course, if the patient is not accepting the orthodontics, my first recommendation will be always the orthodontics. But if the patient is not accepting the orthodontics and I feel I can solve the aesthetic problem being non-invasive, I can, of course, I'm gonna do it and I can do it. So how can I do this? I'm gonna just analyze a little bit this case and I'm gonna explain how to proceed in order to solving this situation without alignment, even that is not so big thing, just little rotations, but of course I'm going to try to solve it being non-invasive. So here, as you can see, well, first of all, the patient's request was decentral, so she was asking just to replace the class 4 restoration. What I suggested to her is to, instead of doing class 4 restoration, I'm gonna perform an additive composite veneer. So I'm gonna, as you can see, this left central is a step back compared to the right one. So I'm gonna be additive a little bit, and I'm gonna just place both centrals in the same plane. So aesthetically, this will just improve only for this reason. Also, we have other things. For example, here in this lateral, I see a little rotation to the distal. So for this little movement, this little rotation to the distal, I am able to see much more the mesial slope, the mesial area than the distal. Okay, so as you can see here, the mesial part is more visible than the distal. And another consequence is that this incisal angle is wider than normal. Okay, so just for being rotated, this angle is wider. The same thing is happening here in the canine. This canine is also a little bit rotated to the distal. So the mesial, this mesial proximal is really evident, really visible. And this angle also is more wider than normal. Okay, let's change the point of view. We're gonna see it better. Okay, so as I told you, this is a mirror image, so it's inverted. Okay, so this one is the left central, the one is a step back compared with the right one. Okay, so I'm gonna be additive here instead of just performing a class 4 restoration that I would be in the situation C. So I'm not doing situation C, I'm gonna do situation B. So I'm gonna do additive treatment, direct composite veneer, additive veneer. So I'm gonna increase the volume from cervical to incisal. And there's a little bit of course, we had the fracture in the beginning. This fracture was fracture line was already smoothed by the last dentist that performed the restoration. So just I remove the composite and that's it. Okay, so here we can see the lateral, as we said, and here we can see the canine a little bit rotated to the distal, being more visible the mesial. The same will happen here. Okay, so my reference point was the central. The central was in perfect position. The patient was happy with this one, so of course I'm gonna take this one as reference. I have this lateral. As you can see, this lateral have a little rotation to the mesial. This time is the opposite, to the mesial. So what it means? That I can see a little bit more this distal. But the patient was happy with this one. I said I can do something in order to just create the delusion that is in the right position. But she said that it was totally okay for her. So, okay, I'm not gonna do anything if she's not, she don't wanna just fix this situation. But what happened? This little rotation here, what create is that this canine looks like is a little bit step back compared to this. This canine is a step back compared with the lateral. So I'm gonna just make a plan here for solving these little situations. And the plan I did was this one, exactly this one. I'm gonna be a bit additive here in the mesial. The composite will disappear as I'm reaching the distal, and I'm gonna create the delusion that this one is in the right position. As I said, I'm gonna be additive here, and I'm gonna just reach the same plane as the other central. The same is gonna happen here. I'm gonna be additive this time on the distal, not on the mesial. The composite will disappear as it reaches the mesial. And also what I'm gonna do is to close the angle here a little bit because this was wider than normal. And the same, I'm gonna perform it here in the Canon. So doing these little things, performing this additive treatment, I can create that illusion that the teeth are in the right position. So I can solve the situation being non-invasive, having the chance of the reversibility. That is, for me, something that is a great benefit, because the patient's teeth are intact down the restoration. Even if the patient want in the future, even I can remove the composite and we're gonna have the original situation. Maybe she's gonna be able to did some orthodontics in that moment, I don't know, but just I would try to solve it in a non-invasive way. Here also I perform some gingivectomies also, and this is how I solved the case. I want to let you notice these white spots that are all around the patient's teeth. So of course I can do some kind of infiltration treatment, and I'm gonna solve this little problem. But she said, I'm happy with this. It's kind of part of my identity, so I'm gonna be happy with this if you keep it. So what it means? That it is necessary to mimic and to copy and to try to emulate here, as you can see in the restorations, these little spots. Otherwise, I'm not gonna be able to integrate, to mimetize the restoration. And this is something complicated. This makes the case more difficult. So this is what biomimetic is all about, to try to take nature as a reference and try to emulate how nature works, how nature looks, of course being conservative. So we are talking about anterior area, so my goal will be try to emulate, of course, how it works, but how it looks. So in order to copy all these details, it's important to analyze all the information that we can get from nature. And this will be powerful information. This will be something that will give us the chance of trying to have a little guide in order to copy, in order to obtain predictable results. But what is necessary is to just search all these details and try to use it in our benefit. So the first thing I do when I receive a new case is to try to, I'm gonna do lots of photographies of the case, and I'm gonna do some photographies of the smile, some photographies, just intraoral photographies, to take all the information I can. So my objective is obtain all that information, notice and evaluate and analyze all these little details that will let me, I'm gonna use it as powerful information, and I'm gonna use it as a guide to follow in order to obtain that predictable results. Sometimes the regular photographies are not easy to analyze. We can have some problems trying to find the details, and we have other tools that will facilitate this operation. For example, we can have the cross-polarized photographies, and we will avoid the reflections. Like here we can see the reflections over the teeth surface. When we have a reflection, we have a big white spot where we cannot see anything behind that white spot. So we're gonna lose a lot of possible information. So the cross-polarized photography helps in order to obtain these little details, and if it cannot be just found in a regular photography. Another tool I like to use, also shown in many articles and publications, is to play or to modify the brightness, saturation with the computer software. this will allow to heighten the effects, heighten the opalescence, heighten the saturation, heighten the all the little details, and obtain all this information. So these are powerful tools, and this will facilitate in a great measure to perform the case. So as I said, it is important to obtain all the information, and for doing this we have to know these different parts, and we have to take all the details that we can. So for example, if we are checking in the cervical area, we're gonna obtain high saturation. If we are looking in the middle part, we're gonna obtain higher value than the cervical and than the proximal area, where we're gonna obtain more gray aspect, because there we're not gonna have any dentin, so we have only enamel. Like natural enamel is translucent, so we're gonna see the deepness of the mouth, so this will be dark, so we're gonna see more gray. So this is something that we have to keep in mind. There are different areas to notice. Of course, if we are checking the incisal edge, we're gonna find lots of little details. We're gonna see the incisal white halo, we're gonna see the shape of the dentin lobes, we're gonna see characterizations, pigmentations, little things, little details that will allow us to just copy the sound central in that difficult cases of, for example, single fracture or single veneer, or even not single, just a couple of restorations in both centers. This is really challenging situation, but we have to try to take all this information. So for these challenging cases, I like to perform what we can call like structural mapping or color mapping or whatever it is called, but just the thing is that it means just sitting over in front of a photography and trying to draw whatever it can be seen. So this can be just no need fancy software, just with PowerPoint, Keynote or something like that, or even over a printed photography, just drawing with a pencil. The thing is just trying to obtain all the information that these photographies can give us in order to facilitate the direct approach and obtain the predictable results. So I'm going to try to find all the little details, all the things that I can see in the sound central, and I'm going to try to reproduce it. Also, I can schematize the primary anatomy, line angles. Just I'm going to have powerful information that otherwise I will not have it. So I'm going to start from zero. So I have all this information that already I have it in my head, or I have it in front of me when I'm performing the direct approach. For example, this is another clinical case. This is a fracture, not so big fracture, but look at this. Look at this edge here. We have lots of little details. If my shade selection here is just limited to one single shade, for example, I'm going to select A1 from with shade guide tab, just for giving an example. So I'm going to check my A1 composite. I'm going to place it there. I'm going to fail because A1 cannot be able to just with one single composite to reproduce all these little details. So in order to obtain that natural-like results and to mimetize the restoration, I need to take all the little details, and I'm going to try to reproduce all that little shades, all that little details that I have. And what I have to just take as reference will be the natural central, the sound central. So I have all the information there. I just have to obtain that information, to notice that information, and I'm going to try to reproduce it. So this means I'm going to have different selections from the composites I have in the office. I'm gonna select a dentin. This dentin will be opaque material, not 100% opaque, but gonna have maybe 65-75% of opacity as natural dentin have. So I will have to select the dentin. I will have to select maybe a chromatic enamel. This will be translucent, more translucent than dentin, but not as much as a chromatic enamel. So for this area, for this central middle part, I like to choose a chromatic enamel. Chromatic enamel allow me to, as it is not as translucent as the achromatic one, allow me to obtain this higher value in that area. I mean chromatic enamel by the composite that have, for example, beta shade guide name. I mean A1, A2, A3.5. Or if it's not beta shade guide name, maybe some brands they are using kind of universal shade, so they don't have this beta shade guide name. Maybe we can find enamel 1, enamel 2, enamel 3. What I mean, I will have these kind of numbers in the name that they are showing that this degree of saturation is increasing or decreasing. So if I have A1, the saturation will be lower, will be lighter shades. If it increases the saturation, will be have more pigment, more chroma. So this is what is the chromatic enamel. So the chromatic enamel is more similar to natural enamel. Natural enamel is more translucent. So we have this material, and we need it for just try to replicate this translucency here. If we don't have this one, we're not going to be able to match it to just reproduce the natural enamel. So this material is not called chromatic, it's called achromatic, because theoretically have no chroma. Yes, have a little bit of chroma, maybe yellow, maybe a bit more yellow, a bit more whiter, a bit more, but it will be no beta shade guide name, and in the name don't have this kind of different degree, this number indicating the different degree of chroma or saturation. And maybe we will have to obtain another material. I wanna, for example, just reproduce this in sizer white alloy. We have different techniques. I'm gonna talk about on the next lecture, but maybe we need all the material. This material can be translucent or maybe can be opaque, depend on the case, depend how I analyze the photographies. Maybe sometimes look more opaque, sometimes look more a little bit translucent. So we will need different materials in order to mimetize a restoration, maybe also some characterization with tints. So we're gonna be able to obtain the natural-like results and to mimetize the restoration. So this is a matter of finding all the details and trying to emulate all these little things that if we are not just focusing on these little things, that little details that nature give, we're not going to be able to reproduce. This is another example. This is a fracture. This is not only reproducing the translucency or the opalescence or the dentin lobes. This is also a matter of reproducing the anatomy and reproducing the texture, because if we are not reproducing this, not going to be able to mimetize the restoration and looking like it is invisible. So this is something that is important to do, to try to reproduce everything, all the structures, also the anatomy and the texture. Something that, in my opinion, is a key for mastering, for obtaining these natural-like results with composite resins is to master the game of opacity and translucency. Mastering this, it's possible to obtain that result because we need to know in the nature where which area is more opaque, which area is more translucent. So just reproducing this, we want to obtain that natural light results because we're going to be more closer to look like nature. Also, composite resins have different properties. There are different filler particles that provide different characteristics, different properties to the material. We have microhybrid or nanohybrid materials that have better resistance, better mechanical properties compared to other ones. For example, like microhybrid, super nano fillers, or nano filler. But on the other hand, these other microfill, super nanofill, they have better optical properties, so are more polishable. We're gonna get a gloss, a final gloss, more similar to the natural tooth. On the other hand, it's more easy to break. So this is a kind of balance. This is a kind of knowing which material we are using, which situation we are using. Is really different working on posterior than working on anterior. So this is something that is important to know and to master and to be familiarized with. Also, not only this, the handling of the composite is important. Materials with less stickiness and with more form retention make easier to work, facilitate the modeling of the composite. So it really just gonna facilitate the work using the materials that maybe are easier for some clinicians. So this is a matter of balance. I'm gonna talk about this the next lecture also. So let's see another example, another clinical case. Here we have these restorations on both centrals. So as you can see, it's visible, the fracture line. Maybe it's not a matter of the shape of the restoration, because the shape maybe is not bad at all, of course, but maybe it's a matter of the material, and maybe it's a matter of we could do a little rounded bevel here in order to try to hide this fracture line. So as I said before, this is just one single composite. This is too translucent. So in order to try to mimic and to emulate all this and this translucency, even here is not so visible, this is not so heightened, this opalescence, but there are different details that we have to try to emulate. If we are not doing, we're not going to be able to just mimetize the restoration. So I'm going to try to reproduce this incisal halo, this translucency, and of course I'm going to try to emulate the shape and the texture and everything I can copy from the nature. So I'm going to be successful if I try to copy as much as I can. If I try to reach all what I can, maybe I'm going to get closer. But if I'm just going to do little details, for sure I'm not going to get close to nature. So this is another clinical case. I'm going to talk about more in deepness in this one. This is really difficult fracture. This is a single fracture, and look at this. This is so difficult to reproduce. We have here this beautiful opalescence, all these little details, and trying to reproduce this in a restoration is complicated, is really challenging. So as more details can be analyzed before starting the work, this is going to be much easier. We're going to obtain more predictable results. So these are some photographies of the stone cast. Depends on where the light comes from. We can see in a greater or lesser degree the anatomy of the tooth. So we can find here the secondary anatomy, and also you can notice even the tertiary anatomy. So this is powerful information. I have secondary anatomy, I have tertiary anatomy that I have to reproduce at the end. So if I know all this in the beginning, this will make it easier when I'm doing the direct approach, because the direct approach, we know that have complications normally in unexpected situations. So this will make it much easier. Here, the wax up, as I said before, I did it myself. I did it in a traditional way. So I try to reproduce everything, all the details. So I practice once, and this will be, for me, will be easier during the direct approach, because I just practice and I solved all that tricky points here first with the ease that represents working on the stone cast. So I can be able to produce that silicon index, and will be easier to bring that design to the patient's tooth. So this is a structural mapping. As I said, I try to draw and to find all the little details, the incisal allo, the dentin lobes, the heightened effects, and I'm doing this over the sound central and mirroring it to the fracture central. So I have a guide that I will have in front of me when I'm performing the direct approach, restoring this class 4 restoration. I will have details of which is the design of the dentin lobes. I will have where are the heightened effects. I will have a lot of powerful information. If I know this before starting, this will facilitate the case, and I'm gonna be able to obtain that predictable results. So I'm gonna have in front of me during the direct approach. This is the day of the direct approach after the absolute isolation. Here, after performing the rounded bevel, after transferring the information from the wax up to the patient's tooth, with the help of the silicon index. So just have transferred the information, perform the first the adhesive approach, just place that palatine, that lingual shell, and here I'm just placing the dentin composite. So as you can see here, how can I reproduce the shape of the dentin lobes if I don't have any more translucency here because of the dehydration of the tooth? So I have lost all the information. The teeth are whiter, the teeth have lost the translucency, so I have lost all the details I have to reproduce. So how can I be able to reproduce this? This is gonna happen maybe in less than 1 minute, as the patient have the mouth open. So in front of me, I have all that information I have obtained it before, and this will facilitate to obtain that predictable results. This is the characterization with tints, because I know exactly where to place these heightened effects, these little things that I have taken from the structural mapping. Chromatic enamel, incisal, allo, and achromatic enamel, for just obtaining that natural touch in a restoration. So as you can see here, the natural teeth are dehydrated still, so the color is different. We have to keep the faith on the selection before, otherwise we're gonna just mess. Okay, so the next day this looks much better. It's important to try to reproduce the anatomy, try to reproduce the incisal allo, the opalescence that is similar to the rest of the teeth, and just follows the same shapes, and just trying to copy as nature is, and then the restoration can be mimetized. can be integrated and just look invisible. So this is the right central incisor mirrored image, and this is the restoration. So as you can see, I'm gonna try to just copy the line angles as well as I know. I'm gonna try to copy the translucency. If here there is translucency, I'm gonna try to reproduce it here. If here I have some hidden effects, I'm gonna try to reproduce it here. If here I have a little bit of translucency, I'm gonna try to do it here because I have my guide in front of me, so this will help me. Okay, so this is like a chain. I like to explain it like that. This is like we have a chain and we have to just master every link and succeed on every link in order to obtain the final result. So maybe we can plan perfectly a case and we can perform the layering process and obtaining natural light results if we are not just treating the composite resin surface as we should and performing a finishing and polishing process to obtain the appropriate results. We're not gonna obtain that optical properties, neither longevity at the end. So maybe we are doing everything well, obtaining optical results, but we can just mess at the end on the polishing process, or even not obtaining that enough longevity for different reasons. The surface roughness is something really critical. A highly polished surface will prevent from flake accumulation, gingival irritation, secondary caries, or surface discoloration. So this is something that is really important in order to obtain that longevity at the end. If we don't have this appropriate surface, we're gonna have different problems, and these different problems will mean that maybe we're gonna fail on the longevity of the restoration. So maybe we did all the chain, all the links of the chain well, and we just failed on the polishing process. So this is something really critical, really important. What literature say is that we should reduce the surface roughness values below these 0.2 micrometers. This is the clinical acceptable threshold to decrease the susceptibility of bacteria to get over the surface, for bacteria adhesion. So if we are just obtaining surface roughness values higher than this clinical threshold, we're gonna increase the possibility of bacterial adhesion over the surface, giving the different problems that I just explained before. Possibility of gingival irritation or inflammation for having more bacterial adhesion, possible secondary caries, staining over the surface. So these are things that are really critical, are really important to succeed and to obtain that longevity on the restorations. So we can think, and how we're going to obtain that levels that have to be 0.2 micrometers or below that 0.2 micrometers. This is really small. How we can know if we are obtaining that surface roughness values? Is visible gloss enough to determine that? Unfortunately, no, because if we are going lower than 1 micrometer, we're gonna start to see that smooth surface. It's gonna look like a bit shiny. So this doesn't mean that we are in the right or in the clinical acceptable threshold. So this is something that we cannot trust our eyes. If just what appears acceptably polished doesn't mean that have reached that clinically acceptable values. So we can think, so what we have to do in order to obtain that values, because we cannot trust our eyes. So what we can trust? So my idea for doing this, what we can trust, what I'm gonna try to follow is what literature say, because there's no other way. We cannot take the restoration and check it down the microscope, because the restoration is in the patient's teeth. So how can we do it? Okay, so let's see what literature say about that. Literature say that the most effective polishing systems are those that just we're gonna systematically decrease the size of that abrasive particle. So it means we're gonna pass from, for example, coarse to medium to fine to extra fine. So if we systematically decrease this abrasive particle, this size of abrasive particle, the surface roughness is gonna get smoother and smoother and smoother and smoother. And this is what we can trust in order to obtain these appropriate values of surface roughness. Literature also say that this is more effective than single-step systems. So it means that if we are using simplified systems, I'm not talking of any system in particular, but we're gonna be more sure to obtain that appropriate values if we are using just polishing sequence than if we are using just simple single-step systems. Maybe there are good single steps that can reach good values, but I'm not gonna be as sure as I am using a sequence and systematically decreasing this abrasive particle. This is a systematic review. In this article, the authors, they are analyzing the effect of different polishing systems on the surface roughness of different composite with different filler particles. So what they did, the authors analyzed 104 articles, and after applying a quality criteria, they selected 17 publications. So that 17 publications evaluated 7 one-step systems, 7 two-step systems, 8 three-step systems, 3 four-step systems, and 4 5-steps. And the polishing protocols were times ranging from 10 to 60 seconds, speeds between 10,000 to 30,000 RPM. So the results that they found is that we can see here the number of steps, and we can see here the surface roughness values. So what they found, they did the average of all that one-step systems analyzed, and the average didn't reach that surface roughness, this clinical threshold, below that clinical threshold. So they did the same with the two-step systems evaluated, and neither they reach it. So as you can see, as we increase the number of steps, the results are getting better, and we are obtaining that appropriate levels of surface roughness. So this is just what, of course, this is a systematic review. There are others also having or showing similar results. So what literature show is that we can trust more the multi-step systems than single or simplified systems, because we cannot trust our eyes. So we have to do something in order to be sure, or at least think that we are reaching that appropriate values of surface roughness. So the conclusions of this article, this systematic review, were that the multi-step polishing systems were the most effective systems in order to obtain that appropriate values, here they found that astropol and stuff like this reached the lowest surface roughness. Aluminum oxide is the most important component, one of the most for obtaining this smooth surface, but also diamond particles are equally effective, seem to be equally effective. But this is not all, because the effectiveness of the polishing system also is material dependent. So depending on the material that we are using, the composite that we are using, we're gonna have difficulties or just differences on obtaining the surface roughness. For example, this depends on the hardness of the filler relative to the abrasive particle, depends on the filler content, the particle size and shape, the filler distribution. So how is this filler particles, how are distributed, which different shape, and how they are distributed. So if there is more resin matrix separating these particles, so it will just affect negatively to obtain that smooth surface. There are different things that affect the effectiveness of the polishing systems, and this is material dependent. So also it is important to select the right material. So in this meta-analysis, what they found is that suprananofill, nanofill, and microfill composite show smoothest and glossy surface in an easy way compared to nanohybrid or microhybrid or hybrid composite in an easier way, and also it's gonna show a smoothest and glossy surface compared to these other ones. We can reach better results with the supranano, nanofill, or microfill. Also, they found that the composite with small and spherical particles tend to show smoother and glossier surfaces and are even more wear resistant, because if we have small and spherical particles, these particles will just fit more closer each other. So we're gonna have less resin in the middle. So this will facilitate the polishing, not obtaining big areas of resin without filler particles. If we have larger and irregular particles, when they're gonna get together, it's more difficult to just fit and get closer. So these are some of the conclusions they found in this meta-analysis. So this is just the explanation of the also the effectiveness of the polishing systems is material dependent. So it's important to know and balance which situation we are facing, what we are pretending to obtain. If we are in posterior, we are in anterior, and knowing which are the results or the goals that we are trying to obtain. So just a matter of analyze well the situations. For example, here these are 2 weeks older restorations. So the patient came to the office and was not happy with these restorations. If we can see here, we have little irregularities. Here we have retention. So this will mean that in the future we're gonna have problems. If these are 2 weeks old restoration, imagine in 2 years we're gonna have inflammation over the gum, we're gonna have staining over that irregularities, maybe it's possible even secondary caries, recurrent caries. So this is something that is important to take care and try to achieve as smooth surface as possible. It is important to polish really well the cervical margin, which is a really critical area. This has to be really well polished also, as well as the proximal areas that are more difficult to get clean and make more retention. So these are especially critical areas that we have to try to keep as polished as possible. Of course, maybe for obtaining natural results, we're gonna reproduce some secondary and tertiary anatomy, but this will be in the buccal area from line angle to line angle. So this is much easier area to get clean, and it's important to keep really well polished all that proximal and cervical areas. And I'm just reaching the end of the lecture. So the last part, and as important as all the others, is talking about the function. Because as I said before, this is like a chain. If we are getting good results, making good planning, getting good results during the layering process, natural like results, we are polishing well, we are selecting well the materials, but we are not considering the function. This can bring to fail on the longevity of the restorations. Is important, as I said. Of course, we have to analyze all the details in order to try to reproduce how nature looks, but also we try to reproduce how nature functions, how nature works. Of course, in situations like this, the request of the patient is to fix this restoration. But if we are not considering this wear process here, look at the canines. Even if we are not considering this, it's possible that we're going to have problems in the future. We're going to have possibly some fractures or some chipping on the edges of the restorations. So it is important to analyze the function of the patient. So if you could notice here, I would like to notice this. Look at the shape of this wear process here is exactly the shape of this incisal edge of the lower lateral, because the lower lateral is passing there, should not contact there, and is have unnecessary contact, so it's making a wear process on the upper lateral. So what is happening here? We have also this worn out canine, so it has lost part of the cusp, it has lost part of the desocclusion. The canine desocclusion is happening here is not enough in order to solve this unnecessary contact here, to jump this contact. So we're gonna have unnecessary contact, we're gonna have wear process going on there, and other, of course, the same can happen in the other side. So what is one of the solutions for solving this? Just to restore also the canine guidance and restore the anatomy of the canine. This will provide enough enough desocclusion. We're gonna have larger canine guidance, so we'll provide enough desocclusion in order to jump this obstacle here and avoid unnecessary contacts. The same in the other side. So literature say that it's equally effective to do it in a single tooth or do it in a group function. So it is possible to do it only in the canine, only or using also the premolars. But of course, it's easier to do it in one single tooth than doing in more than one. So if we are working anterior, it's equally effective just doing this desocclusion from these lateral movements in the canine. So this is another case. Also, of course, as you can imagine, the request of the patient is this. But if I'm not considering this and this and also this, I'm gonna have maybe some problems. I'm gonna have some fractures in the future. So this is something that I have to try to analyze before the treatment and try to just solve when I'm doing the restorations. So let's see how are the lateral movements here. Here we are having some wear process going on. What about the other side? Not contacting yet, so we don't have yet the wear process. But in some time, of course, the wear process will appear or will keep on here, and we're gonna find contact again here. We're gonna have some wear process also going on here. So in this kind of situations, it is possible to lengthen the central incisors, yes, but of course it is necessary to restore also the function and try to restore the anatomy, also here in this case, the canines. We're gonna obtain this better desocclusion, and we're gonna try to, we're gonna have much better protection for the anterior area. So the thing is not only restore nature, how it looks, also how it works, how it functions. I like a lot this kind of formula. It's a anatomy is equal to aesthetics plus function, because if we have an aesthetic problem and we need to restore a fractured tooth, or we need to just enhance a smile, if we are trying to restore natural anatomy as it is, we're gonna obtain both aesthetics plus function, because that's why the natural tooth have this shape and have the centrals and the laterals and the canines have the shape that they have, and also the posterior premolars and molars have this different shape because they have different functions. So just obtaining or restoring this natural anatomy, we're going to obtain both aesthetics, because we're going to have the whole tooth and going to be beautiful, and also the function. So that's all. It has been a great pleasure for me to be here with you guys. I hope you have enjoyed. And let's start with some questions, if there are some questions. I'm gonna also be here, as I said, the next week, and I'm gonna start with just a step-by-step case of some non-invasive direct anterior composites. So I hope I can see you here also next week. I have one question. They are asking, what is the W in white, in W enamel? I guess that asking for the what I was calling the white incisal enamel, or the white halo. This is, I'm just calling white because it's whiter than maybe the rest of the tooth, or it looks whiter for the contrast between the incisal translucency or opalescence, and then a bit whiter halo in the limit. So I just call whiter because is the name I put, but this does not mean that it's white, okay? Sometimes I also use the same tone as the chromatic enamel, okay? When I select my chromatic enamel, sometimes I use the same tone, because in the nature, this is not a whiter area. This is just the natural enamel that is translucent is going around this incisal edge, and just for the game of the light, for the accumulation of a chromatic enamel there, it makes look like whiter, but in the nature is not really something white. But I'm working with not real enamel, I wish, but I'm working with a composite, that is a material that try to emulate enamel, and it do it really well. We can get really natural results with composite, but of course it is not natural enamel. For me, it's much easier to obtain that effect with this kind of whiter enamel, bleach enamel, or depending on the case, I'm going to use different possibilities. But for me, it's easier to obtain this result with this technique. Also, it is possible to do it with white tint, or it is possible to do it just using translucent enamel, achromatic enamel all around the incisal edge, and trimming a little bit with a burr the incisal lingual slope in a 30-degree angle approximately, and will obtain that similar effect. This is more like nature is actually, but I repeat, I'm not working with natural enamel. For me, it's more difficult to obtain the result this way, so I'm trying to use this whiter enamel there. I hope I could answer well your question. There's another question. In this, the question is about the canine guidance. When I'm restoring the canine guidance, these cases I have shown to you is cases where I'm not changing the vertical dimension. These are cases where I don't change the bite of the patient, so I don't have problems with vertical dimension. Just I'm restoring maybe the anterior area for some fractures, for some wear process going on there. So I'm not changing, I'm not doing oral rehabilitation. If it's needed to do oral rehabilitation, this is another kind of treatment. Of course, I'm gonna perform, or we are gonna do it with the team, and then I will have the space enough for restoring the anterior area. But this is a situation where I don't need this kind of oral rehabilitation. I don't need to increase the vertical dimension. So I'm just trying to add the material, the lost material, the part of the cusp that is that was worn out. So I'm just trying to restore the functional part of the upper canine with the lower one for the performing this canine guidance is the lingual mesial on the upper one, and the distal vestibular, distal buccal on the lower one. So when they just get together, they make this kind of movement. So what I have to do is to try to restore. Of course, I have to restore all the cost, but I know that the functional part will be this area. Depending, of course, on the position of the teeth, it can be different, but the ideal situation would be like that. So, of course, first I have to check how is the occlusion, which space I have, and of course I'm gonna do it. I'm gonna design it on the wax app for facilitating the process, but also I can do it freehand. It's just a matter of knowing how it's gonna work, this occlusion, and where I have to place the material for being able to enlarge this canine guidance, this occlusion, and make it more efficient. I don't know if there's other questions. I think for the moment only these two questions. I hope I could answer, and it could be helpful for you. Okay, for the moment, no new questions. So if there are no questions, I guess that this is the end. So happy to be here with you guys. Then I hope you can join also the next week. Let me know. Oh, there's another one. So okay, so they are saying if I touch or I can adjust the mandibular, the lower teeth to have a perfect guidance. I'm just gonna, as I said before, I'm just gonna check how it works in the original situation. So I'm just gonna notice which areas are working, which are the functional areas of that particular situation of the patient. because of course every patient is different and we're not gonna find always the ideal alignment. So we have to deal with different situations. So I'm gonna try how it is. Imagine if for the alignment of the patient, if the canine are not contacting, is impossible to do any improvement of the canine guidance. So I have to check it. I have to check how it works. If I have the space for doing it and for performing this kind of enhancement of this occlusion, and after that, I'm going to try to solve it only with the upper one. If I can increase this disocclusion with the upper one, so I am supposing I am working in the upper anterior, so I'm going to try to just fix it with the upper one. But of course, sometimes just fixing it with the upper one is not enough. So then I'm going to have to explain to the patient, I have to do some little adjustments to the down part because I need to enhance this disocclusion. I have to explain for what, and this is kind of functional thing. So the adjustment will be also adding a little bit of material, being additive for just enlarging this occlusion, if I can, of course, if the situation allow me to do. But it's important, I have to check and I have to analyze the situation before starting. After that, I'm gonna be able to know it. For the moment, no more questions. Okay, another one. They are asking if the patient has deep bite, do you first solve the problem on the posteriors? If the patient have some problems on the alignment and requires some orthodontic treatment, my first recommendation will be the orthodontic treatment. As I said, there is, of course, we have an ideal situation, and in this ideal situation, this work with this, and we should increase this other area, and the canines work perfectly if we are restoring. But if we are in some situations, if the just alignment is not how it should, of course, we're gonna have different difficulties for just performing the treatment. Of course, if there's a problem that requires orthodontics first, my recommendation will be the orthodontics, because this is the way for solving and will improve not only the aesthetics without doing anything else than alignment, just will improve the function. So this is my first option, my first recommendation. Of course, there are different situations. Sometimes the patient is not accepting this kind of treatment. So as I said before, if I can be able to solve it in a non-invasive way, okay, I'm gonna do the treatment and I can accept. But of course, these situations we're gonna have more difficulties than regular situations or situations after orthodontic treatment where the alignment is just improved, and this is gonna be much easier situation. But of course, I'm gonna try to recommend the orthodontic, because this is the way where I'm gonna have a better situation and easier situation to solve the problem and to obtain better results. And even more, for me, the most important thing, to be non-invasive, that this is the first objective. Let's see if there's some other question. It looks like this is a quite thing of a function. People want to know about the occlusion. Okay, let's wait 1 more minute. If there's some other question coming, if not, we're gonna finish. Of course, there's much more things to explain. We can go deep in much other things, but of course there's not time enough for doing everything. I invite every one of you, if you wanna come to some of my courses, and of course I'm gonna have more time for explaining more deeply about all the details, but for the moment here is the time that we have. And I repeat, I'm gonna be here next week also, and I'm gonna be I'm gonna explain more details about the whole process, the step-by-step process, and of course I'm gonna explain all the things. I'm gonna add all the details, and I hope it would be enough for you for these 2 lectures. Of course, I keep much more information that I would need maybe 3 days, or I don't know. It looks like there's another question. I'm not sure. Okay, so there are no more questions. So again, thank you so much for just being here. I hope that you could enjoy with my lecture, and just it's a great pleasure for me to collaborate. And let's see you next week if you want to join. So bye bye.